Good afternoon, everybody. Before I thank Dr. Rajiv, I would like to thank everybody present in the auditorium here. Probably will skip your lunch. Maybe you are more interested in this presentation, this 1 hour program, or maybe you have to participate, but I must thank you a lot. And then I thank Dr. Rajiv for including me in his team for this beautiful 1 hour course, custom gastric surgery and how to optimize our visual outcome. And I'm here to take care of the different type of lenses, their merits and demerits. You can see here there is a picture on the wall. What you would like to see the list, what your wife has given you to the phone. Then you have to bring this grocery or some items from the store, and you are wondering where they are. And then once you have a cataract, you can see all hazy. And when you want to put a monofocal IOL, you can see only certain things. You cannot see near. And if you want to have monofocal lens or the lead, then you need your far vision. But you have a multifocal lens, then you can see everything clear. So let us understand we must know what are the plus and minus points of different lenses. So multifocal actually is a misnomer now. It is a bifocal lens. It provides a wide range of vision. It maximizes image quality. It reduces the photopic issue. The photopic vision is very good. It is independent of pupil size, not the pupil position. And some amount of field of vision can be achieved. And with this bifocal, multifocal, you can have excellent stereopsis. However, there are limitations. Mainly, whatever different type of multifocal you use, either thermal refractive or diffractive, but then it depends on the pupil position, and it decreases the contrast sensitivity. As we know, certain lenses have a lot of problems about the glare and the halos. Of course, this in our country the expense is a prohibiting factor and not suitable for all occupations. Then there is another one, accommodative lenses. Rajiv is expert, he is using it a lot. It has monofocal optics, distant, intermediate and near, all vision, it covers a lot. Good, very good visual quality. But your pupil size is independent and 100% rays are focused for focus object and usually no glare, no halos. However, you need to have a larger incision. The incision is slightly difficult for the beginners, and 6 may not be achieved in all cases. And if the axis is not intact, then you cannot implant. And over a period of time, when the fibrosis of capsule occurs, then it hampers accommodation. And it is a silicone material, so in certain conditions, particularly with retroviral disorders, it's not advisable. Now the trifocal lenses have come. You can see what here, the bifocal lenses. The first order for the near is focused here, and for the far it is here. But in trifocal, you can see it's excellent intermediate vision without compromising distant and near. You can see here the parallel rays are here. Okay. You can see the addition is 3.33 and it is focused for near. Then there is one for the far and there is intermediate where the power is 1.66. The trifocal has a very good advantage in comfortable reading distances and smooth transition for near, intermediate and distant vision. However, there are limitations. Night vision is issues still to be handled, pupil dependent, very, very expensive, and long-term follow-up is lacking. So I would, this is my first presentation about different types of lenses, merits and demerits, and I will go to the next one immediately, where I would like to share my opinion, and I would like to have your opinion too, for mix and match. modern cataract surgery is now becoming a refractive surgery. Only good frequent surgery is not enough because the expectation of an intermediate has gone very high. They don't want any glasses for entire range of vision. Moreover, they don't want only quantity, they want quality vision also. And of course, now everybody is using some kind of vehicle, maybe at night time also. So minimum night vision disturbances, and it should be affordable. The present scenario in the market, the IOL, the quality is definitely much better now. There is a wide range from -5 to +40 cylinder up to 10, and maybe they can customize. If you are still higher, they can probably provide you. The quality of vision is definitely improved, but there are inherent issues like spherical aberration. Now it is the talk of the, it gives a lot of spherical aberrations. And people, the market people, the trade people talk about that we have spherical aberration, this value, that value, and of course the accommodation and the glare. No IOL is perfect, and one IOL doesn't suit everybody. So we have to go for this mix and match. We have seen the merits and demerits of different lenses, other lenses, but I would like to summarize about the monofocal lenses. Here the vision, whatever is select you for the distant or the linear, the vision is, that part is excellent, but then other linear or the intermediate is compromised. Pseudoevacuation, you can have some. Of course here, the night vision problems are less. And with the zero spherical, because they are now available with different spherical aberration. The zero spherical aberrations, monofocals, they have pupil size independent, no issue with the decentration, good for the pseudo exfoliation, and this is very important, very plus point. You have planned for all other higher lenses, but if there is issue, like PCR or columnar diet or something like that, no, you have to come to the monofocal. So this is the greatest advantage. So therefore, the combination of different IOLs, mix and match, are necessary to enhance the binocular vision. As we have seen, monofocal, multifocal, accommodative, and now trifocal. Now why? Because we have patients, those who have been operated in one eye before few years, where they had monofocal. Now they have changed the profession, or their requirement or their need is increased. Now they know they have information, so they would like to ask you a question. They say, can we have multifocal? Other eye, can we have this, that? So you have to be ready for that, and you should know. So that's why just want to have the mix and match is a good concept because it gives you range of vision, particularly when one eye is already implanted with the previous IOL. Quality of befogging is scotopic vision we have to consider, and of course the stereopsis. The visual acuity is look at the different combinations. Visual acuity is very good with two multifocals because it has now with the +3 edition and +2.5 edition. So this is with the near, they are all covered very well. And of course multifocal and accommodative. Again, the visual acuity is very good for all range. Now we are talking about the mix and match combinations. The quality, the halos and glare, there are hardly any with the monovision. And monofocal and accommodative, again you cannot have, or very less. Contrast sensitivity part is good with monovision and monofocal accommodative. And stereopsis is excellent with both sides multifocal. And maybe multifocal with accommodative, again, good. There are other issues. Suppose you want to implant in the lens improper, the complications. Then only monofocal lens is possible because you would not like to take a chance. If there is a decentration, again monofocal will not have problem. And if you have the cataract is associated with some other diseases, again you don't want to take chances like diabetic retinopathy, where they or maybe AMD, where the vision you know that the outcome will not be that good. So you have to come confine with the monovision concept. Let's see. What will be your mix and match recommendations like professionals, doctors, architects, and lab people? What will look at? Anybody on the panel, Raji? Dr. La, Dr. La? Or anybody from the audience, please? Monofocal, monovision? This monovision. One for distance, one for near? Okay, fine. Anything? Professionals.
I'm quite comfortable using glasses. I rather with the good progressive glasses available, if you have the sharp.
So you will do monofocal for distance, both eyes, both of you, and near for glasses. But the person doesn't want.
Especially if they are myopic, slightly myopic.
Okay.
I will prefer to keep them myopic because myopic person are very unhappy when you give 6/6 vision.
You will leave little cylinder, they will be more happy. Madam, what about you?
The question is not whether it's a professional or non-professional. The question is, it is a psychological makeup of the patient and doctor's ability to overcome his questions and concerns. And doctor's patience to counsel after surgery, because most of these patients will spend more time after surgery than before surgery. And assessment of how that patient is going to be. So you want to answer?
No, sir. There are other professions we are discussing later on. But particularly for this, and they don't want glasses. See, they don't want glasses. If they want glasses, then no issue. If they are happy with glasses, why we should worry?
So then again, there are many multifactorial things. I mean, suppose patient doesn't have to drive and he has no driver and he is...
so you will not go for multifocal? Yes, particularly those give a lot of night glares and halos.
He has got a driver and if he wants to have...
we have to take care.
By and large,
but there are some...
have then one monovision is a good option.
Monovision is a good option.
1.75.
But sir, in that case, the intermediate vision is really compromised. Like surgeons, we have to look at the trolley, or maybe you have to work with the computer. So that intermediate vision is compromised.
Actually, so as trolley is concerned, even the distance vision without the glasses you see reasonably well. I mean, there is no problem in identifying which instrument you are picking up.
Yeah, assist is there to assist you.
So, anybody who has 1 meter distance, without glasses, it's a reasonably good vision to identify such an object.
What about the teachers? Anybody in the audience, sir? What will be your mix and match? One eye is operated. They don't want glasses, sir. That is our main concern.
Probably diffractive multifocal.
Now teachers don't think that they are poor. They are very rich now. When they run classes, private classes, they make a lot of money. Probably more than an average ophthalmic surgeon. Not like you, but otherwise other surgeons. Average surgeons. So they can afford multifocal. What is it? Anyway, sir. Anybody? Monofocal plus multifocal. Good, sir. Anybody?
Sir, if I use multifocal, I use in both the eyes. And depending upon, if I'm not from 2.5 as effective as 3 actually. Some of the other I'm not very happy with 2.5. There is a little less glare and halos, and you can work on a computer. But it gives you little an addition, which is 0.5 after weather can give that much of addition. So why to bother for such an explanation? So I personally have moved back to +3. We really want to have some substantial good.
Sir, our point is, there are 2 points. Number 1 is refractive. We want to have a refractive, means no glasses. Let us understand. See, whenever they want glasses, fine. But no glasses, number 1. And
I use +3 the refractive multifocal.
Okay.
Over +2.5.
To both eyes.
+4.
You can have in one eye 2.5 and one eye +3.
Multifocal mix and match.
Yes, mixed match of the 2 power.
Everybody agreed here in the hall? I think it's all possible. When they have operated for one eye.
We do it with drivers actually. Professional drivers like use glass driver and here.
Sir, multifocal? But they don't have glare and halos problem. Many of the patients, I mean most of the patients, they really get. Professional drivers, anybody other than yourself? Multifocal, bilateral, anybody else? Madam,
Dr. Shroff.
Okay, fine, we go fast. So monovision, monofocal plus multifocal, monofocal, these are my
You are covering the panel discussion.
Okay, fine, thank you very much.
I request Dr. Harbans to speak on one-side planning and NRI.